We have organized each listening session by stakeholder or constituency as listed here. Today, we kick off the session with multilateral partners, private sector, and private foundations. The format of each session will include a brief presentation, which will later be disseminated, a facilitated panel of esteemed stakeholders, moderated comments and reflections from all attendees, and finally, a summary of key themes toward the end. All of these sessions will be recorded. Moving into the epidemiologic and PEPFAR overview. Here we see the global HIV/AIDS situation. On the left, we see significant declines in new infections and deaths since 2003, and the global treatment cascade on the right. These collective successes are a result in large part of our collaborative effort to scale prevention and treatment programs around the globe. Looking regionally, we see Eastern and Southern Africa with the most epidemiologic impact as a result of controlled epidemics in many high-burden countries. Here we see trends in new infections and deaths on the top, distribution of new infections by population in the bottom left, resource needs, and the testing and treatment cascade, as well as gaps. In Western and Central Africa, we see continuing declines. Similarly, as well as in Asia and the Pacific, we see continuing declines. And here, of course, we have concentrated new infections. In the Caribbean, we also see continuing declines. And in Latin America, we're in a relatively steady state. And in Eastern Europe and Central Asia, we see increasing trends in new infections and deaths, and of course, a concentrated epidemic here. What has remained consistent is the unwavering bipartisan congressional and presidential leadership and support of PEPFAR since its inception in 2003 to present. As you know, PEPFAR provides support in 55 countries, and our investment is aligned to HIV burden. Here's a summary of PEPFAR's latest program results. We have 18.2 million people on life-saving treatment, with an additional 1.1 million in the past year alone. We continue to make great strides together in circumcision, orphans and vulnerable children, HIV prevention among adolescent girls and young women, as well as other indicators. Here we see the trends over time of PEPFAR's budget, which is the blue line, and the increasing results of circumcision in yellow and treatment in the blue bars. And our commitment to treatment continuity and growth is clear, despite the peaks in COVID-19, as depicted here in peach. We're seeing significant progress toward UNAIDS 95-95-95 goals. Here are a select grouping of countries across Africa where we have results from the population-based surveys, and we see community viral suppression in orange. We've made strides together with private sector and foundations on preventing new infections among adolescent girls and young women through DREAMS, which we're really excited about. And we continue to make progress as well as see gaps in our key populations programming, as depicted here across this slide. We'll go quickly here, but to show that there are a number of countries at epidemic control of HIV. And before I go through these slides, just a huge thanks to UNAIDS for much of the data that is presented here in this deck. So I'll pause for a minute. These are countries that are at epidemic control. Again, we're just going to scan through these. Another series of countries at epidemic control of HIV. And here, at epidemic control of HIV. Here as well, at epidemic control of HIV. And finally here. The next set are a set of countries that are near epidemic control of HIV. These listed here and here, again, near epidemic control of HIV, and here. And finally, we have a series of countries with declining new infections, but not yet at epidemic control. These include the countries listed here and the countries listed here that are not yet at epidemic control. And I just want to pay attention to the y-axis, which is very different across these countries. And these countries not yet at epidemic control. And looking at gaps, opportunities, and the end state. Again, showcasing important data from UNAIDS in terms of distribution of new infections globally as well as regionally, as well as by age and sex. I just wanted to make two key points here. First, in sub-Saharan Africa, despite these gains that we've just seen, 52% of the new infections are among 15 to 49-year-old females, even though they account for only 24% of the total population. So we must continue to decrease new infections in this population, particularly as we consider the youth bulge. Second, there's variability of coverage and accessibility of critical HIV prevention services for key populations across countries and regions. We must continue to focus on these populations and address critical barriers as well. Here we see the coverage of ART by adults and children over the last decade, and 2 points to make here. First, 40% of children living with HIV had suppressed viral loads in 2020, compared to 67% of adults. And second, nearly 2/3 of these children not on treatment are among those aged 5 to 14. COVID continues to be a vulnerability affecting the program and the beneficiaries we serve through PEPFAR. We've been adapting the program for the past 18 months to protect the gains, accelerate the progress, but also to help respond to COVID-19. By leveraging this robust platform that exists around the globe that PEPFAR investments have strengthened over time, with labs, healthcare facilities, healthcare and community workers, as well as supply chain. Here we see HIV investments by donor. In red, it's PEPFAR, blue, the Global Fund, gray, partner country investments, and in orange, other funding, other donor investments. And here we see projected gross domestic product growth versus HIV prevalence. And it's clear that economic problems across the board are experienced because of COVID-19. Particularly in countries with high HIV prevalence, as you can see in the red dots, and as well as high income status. One very important component to our approach to sustainability is delivering services through local partners and communities. We currently have 55% of new funds going directly to local partners, as shown in blue. This varies by country and by care and treatment, as you can see in the middle graph, as well as by prevention on the right graph, while their prevention funds going to local partners is at less than 40%. So in the end, what does a sustained response look like? We see various factors that contribute to a sustained response. A whole of domestic approach from government to community, sufficient functional, technical, and managerial capacity, financially sustaining essential services, HIV service delivery integrated into the broader public and private delivery systems, robust public health response to monitor and track existing and emerging threats, and finally, quality assurance to effectively manage and monitor services with positive health outcomes. With that as the backdrop, we're moving to what brings us here today, the PEPFAR 5-year strategy development. We started developing the strategy with your help since last fall of 2020, as bulleted here, and we look forward to continuing to hear more discussion, deliberation, inputs, and reflections from all of you. This month, we're engaging in a number of stakeholder and constituency listening sessions, as I talked about earlier. This will feed into both the strategy itself, as well as our country operational planning 2022 guidance development and longer-term planning. The strategy is focused on achieving sustainable, equitable, and resilient control of HIV. We must together support the global efforts related to the SDG Target 3 and must be closely coordinated with the Global AIDS Strategy, recently released by UNAIDS and adopted by all countries, as well as the post-2022 Global Fund Strategy. There are 3 proposed goals and a series of objectives. I won't read all the objectives, as you all have been given this in PDF form. Goal 1 is to accomplish the mission 95-95-95, sustained, equitable, client-centered HIV prevention and treatment services, with 6 proposed objectives as listed here. Goal 2 is to build enduring capabilities, resilient and capacitated country health systems, communities, and local partners, with 5 proposed objectives listed here. And finally, goal 3 is to broaden the base of support, partner for greater impact, burden sharing, and sustainability, and 5 proposed objectives listed here. Now I'll hand it over to Mike Ruffner, a deputy coordinator at SCAC, who will facilitate our esteemed panelists, which will reflect on these questions here. Mike, over to you.
Thanks so much, Andy. So welcome to the next part of our program today. We are going to have a panel discussion, a very, very strong panel today of what I'll just characterize as the funders and the standard bearers for the HIV response. So joining us today, we have Shannon Hayter, who's the Deputy Executive Director at UNAIDS. We have Siobhan Crowley, head of HIV at the Global Fund. Meg Doherty, Director of HIV, Hepatitis, and STI Programs at WHO. Adrian Thomas, Vice President for Global Strategy Programs and Policy for Global Public Health at Johnson & Johnson. And finally, Peter Ehrenkrantz, a Senior Program Officer at this little fund in Seattle that does a little bit of global health on the side. No, sorry, the Gates Foundation. So what I'm going to do is I'm going to ask each of the panelists a couple of questions, and I'm just going to dig right in and start off with Shannon. So Shannon, my first question to you, and this is a question that I'm going to ask of everybody, is in essence this: what is missing in our strategy? We've laid it out here. Are there some areas that we haven't considered? I do think that a more interesting question in that is, are there points of emphasis, or are there things that we don't do that are part of our strategies that we should do more of? So there's that. The second question that I want to ask you is that we know how to end the HIV/AIDS pandemic. However, we are really we're confounded by stigma, by discrimination, by ineffective policies. And a lot of the results of those problems are what at the heart of the inequities that are part of the new UNAIDS strategy. What can the PEPFAR program do? We can't control for these things. We can't even fix some of these things, but nevertheless, we have to confront them. From your perspective, what should we be doing? Shannon, the floor is yours.
Great, thank you, and thank you so much. I'm really excited that PEPFAR is sort of restarting these listening sessions, and it's really a pleasure to be here with you all today. And I think, Mike, really building on the first thing you asked is what else, what more, what new, and I should say for the whole next strategy, for the Global AIDS Strategy 2021 to 2026, one of the messages UNAIDS is trying to give every single, member state is that this next 5 years requires really bold action. And to get us from where we are now to where we need to be, can't just be more of the same, even if the same has been really, really good. Every single country has more left to do, and every single country can help contribute to that global momentum to achieve more. And I would say on that, you know, the US government is really unique in its role. It's not just unique because it's a bilateral who also plays in the multilateral field. It's not just unique because of the volume of development aid, but it's very unique because of this construct of PEPFAR, which promises a whole of US government sort of coordinated, leveraged approach to apply to the global response. And that includes the ability to tap into broader health and development goals and investments, and the ability and mission to use diplomacy and influence to sort of pull the world and lead the world to where we need to go next. And so I think in those mindsets, you know, there are probably 5 things I would say really deserve some attention and some unique, I guess, unpacking for the next PEPFAR strategy. First is, you know, what are the new parts of the 2021 to 2026 global aid strategy that I think, given that unique role that PEPFAR has, we would like to be able to depend on you more for. And I think this has to do with not just services and systems, which are captured in the current 2-pager, but also societal enablers. And I would like to demystify societal enablers and say, yeah, you don't need to control them, but they are technical and programmatical and ability to achieve results should they be invested in with evidence-based investments. And this includes, you know, adopting the new 10-10-10 targets. That less than 10% of countries have unsupportive legal frameworks, less than 10% of people experience stigma and discrimination or gender-based violence or gender discrimination. I think second includes having an explicit commitment to the role of community-led organizations, which is different than just community-based or client-centered, is community-led organizations. And I would say in sort of the full PEPFAR remit, this is a place where your democracy and governance investments should really care as well, because having a robust community-led organizations gives you robust civil society. Invest in the better legal frameworks and the anti-discrimination, and this is where your human rights experts come into play as well. Second element I just wanted to promote is I would ask you to showcase the United States commitments to the remaining work they have to do at home for HIV. I was really thrilled by and blown away by the PACHA meeting last week, in which Harold Phillips really highlighted a commitment to addressing the disparities, the racism, decriminalization, structural determinants for the remaining most affected people living with HIV in the United States who haven't been reached yet. And I think that showcasing for the global world also highlights something your National Security Advisor, Jake Sullivan, is known for, which is saying, you know, we are better abroad when we can show how we're trying to become better here at home. Third, I would encourage you to really highlight the multi-sectoral response in your next strategy. Yes, you highlight SDG 3, the, you know, health for all, and that's fantastic. But I would also point out that our global aid strategy crosswalks not just to SDG 3, but to 1, 2, 3, 4, 5, 8, 10, 11, 16, and 17. Talks about poverty, hunger, health, education, talks about gender equality, work and economic opportunities, inequalities, cities, justice, and partnerships. So I do believe there's opportunities, again, to mobilize other US government investments in these larger problems in ways that will support better outcomes for HIV. You know, PEPFAR's done this amazing job with DREAMS of both investing directly and showing as a proof point that, for example, you know, investing in keeping girls in school through secondary school works for HIV prevention. I'd like to see a world where we have those investments from education and the departments of education worldwide, so they don't just have to come out of the HIV budgets, be they PEPFAR or national. And then fourth, I don't think a strategy will be effective unless it really grasps this moment in time, the context for global health in which we find ourselves right now. So yes, the COVID and the post-COVID recovery and resiliency that HIV is contributing to. But I would also challenge us to think in terms of not just systems, but also surges in that next phase. So we think about vertical transmission, or we think about loss to care or loss to follow-up. Yes, we have some system changes that will continue to make this better. You know, we have to work on getting to 100% EID so we stop missing these babies. And that will be something that has to sustain over time. But doing that won't find those 800,000 children who are living with HIV, not diagnosed and not in care right now. I would ask us to challenge each other to say, what can we do as a surge in the next 2 years, the next 3 years, a one-time thing to go out and make a supportive environment that helps families and kids come back in what they need. You can say the same on loss to follow-up for those who have had challenges during COVID. And then finally, I really liked how Anjali highlighted, you know, some countries have reached epidemic control, or as we say, epidemic transition, you know, so that the epidemic can start getting smaller instead of getting bigger. And I would point out, you know, the idea that we are controlling an epidemic without a vaccine and without a cure, you know, needs to be highlighted. Like, this is a big deal. But I would ask also your help in highlighting to players around the world that once we reach these epidemic transition points, it doesn't mean we're done. And it's not just about sort of carrying on treatment for those in treatment, but what are the systems and approaches that are going to be needed, that we need to invest in now so that we can make sure that as time goes on, countries can rapidly identify, detect, and respond to new pockets of HIV or directions going backwards or areas or people or community that need more investments too. So those would be some of my thoughts on where PEPFAR and your strategy can really help lift the entire global response going forward. And I think get the most out of those US government taxpayer dollars that you're investing. So thanks, Mike, back to you.
Thanks, Shannon. Excellent points. I'll just underline that the thing you said about the US response internally has to get better. I don't think that comes up enough, and that's a really important point for us. Do as we do, not do as we say type of an issue. Thanks for that, Shannon. Meg, the second question goes to you. Again, I asked the same question. What are we missing, if anything? What are some of those points of emphasis? But my second question to you is obviously we are in the midst of the COVID pandemic, and it is going to have not just the short-term immediate effects, but there are going to be long-term effects that are coming out of COVID. How do you think over this next 5-year strategy period that PEPFAR should be helping to mitigate the effects of COVID and accelerating our reach for epidemic control in a sustainable, equitable, and resilient way? Thanks, Meg. The floor is yours.
Thank you. Thank you very much, Mike. I'm going to turn off my video because I seem to be coming in and out, so I hope I'm not lost at any point in time. But these are really important questions, and I would just say that I support also what Shannon brought up, and I wouldn't necessarily be able to say it any better. But I think the multi-sector environment is going to be really important for both COVID and HIV. One thing I did want to reflect on first on the question one of which I think is going to be also important for COVID, is seeing also how we can ensure that within the systems and services and partners highlighted in the strategy, that there's clear leadership role for the Ministry of Health and the government, and that they're at the center and leading, because I believe a government country that is able to take all of this on will be better placed in the future after we reach 2030 and after we see what the next will come after the Sustainable Development Goals. And so in that light, it's important to reflect the global health architecture regarding the UHC 2030 primary health care and sort of the focus also on integrated service approaches as well as health system strengthening. I know those elements are there, but I think it would be really important in your strategy to highlight where the really strong development of services and that have been so important in COVID are now leveraged and are being leveraged. And what you've seen now is that the work that has been done on developing laboratories, the work that's been done on developing data systems, on surveillance, on training healthcare workers have pivoted very, very quickly and been used for in the COVID setting. And I think also there are opportunities in the global health architecture as millions of healthcare workers and outreach workers who've been focusing on polio, how are they getting integrated into what might be needed for both COVID and for HIV service delivery in the future? And then from another place is to ensure that their policies, when I looked at the data presented by Anjali, we know that their burden is so great in Africa, and we know that there are leaders there, but we also see that we're not doing well in Latin America, and we're certainly not doing well in some of the Southeast Asian countries and Central Eastern Europe. These barriers may be able to be cracked easily with the support of the private sector, with getting the best medicines at a reduced price. And it's a small, for a great return, it's probably a smaller investment. So it would be great to see, like in the US, for some of those small, that progress is being made. Because once you do reach epidemic control, if you can also understand that you have to keep investing and ensuring that the smaller epidemics, the local epidemics are being treated just the same urgency, then we'll certainly see in 50 years that we're back at square one if we'd never have a vaccine for HIV or in our lifetime. Going on to COVID and HIV, I really have 3 points to make, really. There are the direct effects, which I think are urgently needed to be addressed now, and I think PEPFAR is in a very good place for that. Not only do we know that people living with HIV can be at an increased risk of mortality in the data that we're seeing once hospitalized, there's emerging evidence that also that people who may not be virally suppressed may have a more difficult time clearing COVID, and this could be also a nidus for new variants. And certainly, we see that COVID is going to be with us over the long term. It's not something that's going to end in a year or two. It will be here with us for, I think, the 5 years of your strategy. So looking at the vaccination coverage in the countries that are funded by by PEPFAR, it would be very important, I think, to think about how to ensure vaccination coverage for people living with HIV. Now, that's just one direct actions. In terms of the indirect, I think we've learned so much about the service innovations and service delivery that have worked really well. I don't believe these has been taken fully to scale, and ensuring that those service innovations, whether it's multi-month prescriptions, DSD for children, DSD for pregnant women, ensuring mail services, ensuring there's more self-care and self-testing. I think that's a great place for investment in terms of also long-term investment in self-care. And that's people-centered, but also in the hands of people as well. I think there are many evidence-based interventions and many recommendations in science that is new, that is out there, but have not yet been fully taken up. So whatever we can do cohesively from WHO, from all the partners around the table, ministries of health are taking up the policies. And lastly, I think it's important to also know how your data is being, there's a risk that we could have so many data systems already developed and laboratory systems, and that there could be a lot of duplication, especially in the time of COVID. So how are we organizing this at country level that are available? And lastly, I think bringing in the control of comorbidities. It's mentioned, I believe, but I think it's going to be crucial as people age with HIV, as people who are at risk for COVID include those with multiple comorbidities. I think this will be a very important interventions to bring forward in your services element of your strategy. So with that, those were my main points, and I'll stop there. Thank you very much, Mike.
Thanks, Meg. You know, those are really important points, particularly, I mean, you're really talking holistically about the system in many ways. And I think when you started off, one of the things that we don't always appreciate about PEPFAR are the spillover benefits or knock-on effects of what we invest in. You know, we are building a pandemic response that has been leveraged, and I think it's a good point to make us more thoughtful about that. Thanks for that, Meg. Siobhan, the next question's for you. We, with the Global Fund, PEPFAR and the Global Fund, really are joined at the hip in ending the HIV epidemic, and we both, I think, have to look down the road a little bit. So the first question to you is the same one that I've asked of everybody else. You know, is there something that's missing? Should we be emphasizing more? But the second question I really want to probe is, as we look down the road, what should the PEPFAR program look like at sustained epidemic control? And what really, I think, are the most important part of this question is what are the threats to maintaining epidemic control over time? So with that, Siobhan, the floor is yours.
Hi, can you hear me? Yeah?
Yes.
Great. Hi. Well, thanks very much for the opportunity to contribute to the listening exercise. And I have to say, I quite like the simplicity of you know, how you've presented it, and I think that the draft vision captures three, you know, the components well, and it is understandable, and it's nice to see accomplishing the mission sort of alongside the enduring capabilities and then broadening the base of support. That makes sense. In terms of what might be missing, I think there's a couple of things that integration is sort of not mentioned or clear, and it's, you know, while I struggle with the word myself sometimes, it's critical. And I think balancing between, particularly sort of thinking about integrating in terms of health systems and precision public health and what that looks like, and balancing between pandemic preparedness and our preoccupation, quite rightly so, with the global pandemic, but also the evolving modalities of UHC, because actually, you know, as you know, I mean, HIV is both a transmissible infection, but also behaves essentially like a non-communicable disease at the end of the day. And so walking that line, and there's probably a little bit more weighting as it reads at the moment in sort of configuring to pandemic preparedness than perhaps to universal health coverage, and actually that further evolution and differentiation of care models is going to rest upon the evolving model of UHC. Second thing I think that might be missing is, you know, the demographic transitions occurring. So in Africa, we have to acknowledge the need for promotion of sexual health and the provision of sexual health services, irrespective of gender or sexuality or whatever. And the other demographic transitions elsewhere, which are moving to sort of aging cohorts and a very different type of transition. And that piece doesn't come out particularly strongly. I think, I mean, other than that, there's nothing. I mean, the other sort of striking thing that isn't clear is the prevention targets. I think it's super clear, 95, 95, 95, as Shannon mentioned. I think we have to, all make ourselves a little bit more accountable for what progress we expect to see there and which results we want to tie ourselves to. And I agree, it's difficult. We're struggling. You're struggling if you look at your data dashboard. I mean, BBMC's there, but some of the other really high impact ones are not there. We're not positioning PrEP. We're going to have a whole new suite of prevention tools coming along, and we need to make sure that they're seen as an imperative. So to your second question, your difficult question of what does the PEPFAR program look like at sustained epidemic control of HIV, something to which, as you say, we are absolutely tied at the hip about trying to deliver this and the threats. I think the draft vision does get the sort of three components of a sustained, epidemic control, 95 by age and sex, resilient lab surveillance and integrated public health response systems, and leveraging partners. But there are a couple of gaps. So for me, the prevention activities for key populations and those targets, I don't think we have a consensus definition of sustained, equitable, and resilient HIV epidemic control. We have a couple of epidemic parameters. UNAIDS is offering us several different ways to interpret. But if you think about what that term means, it means there's a time element to it, there's an equity element to it, there's a resilience element alongside those epidemiological definitions. And reading through the lines of what both Shannon said and others have said, what is a sort of healthy domestic response look like? Funds have got to be on budget. There's certain things there that we haven't actually, we haven't given an operational definition. And frankly, I think we're going to need that, because it's going to be easy to sort of pin it on some of the epidemiological definitions, but less easy on the operational definitions. And then, as I mentioned, I think silence on sexual health. 90% of transmission is through sexual activity, 10% through drug use at this point in time. And so to not be explicit there, I think, is an issue. And I understand that's particularly troublesome, perhaps, and is intensely political. But likewise, I think we do need, if we're going to start talking precision public health, we just have to talk about what drives the epidemic. I think in terms of the threats, COVID Meg's touched upon, and we know. I think the limited local host government funding and engagement, it's not just funding, it's engagement. We've seen people step away from the nascent sort of commitment and being engaged. And as Shannon said, the societal enablers are fundamental. That's the sort of fabric in which we're trying to operate. And when they're so easy to walk away from, we won't see this sustained response. The absent position on sexual health and the need for those sexual health services, you look at the demographics of Africa, you have the largest ever cohort of people who are going to be staying in school longer, delaying marriage, delaying first child, which means that, it has to mean that there will be sexual activity that is not leading to procreation and is not leading to, is not associated with marriage. So we do need to talk about that. I think there's the problem of building siloed systems and those service delivery models for the future. We've really seen how HIV is been the exemplar in a way for things like differentiated service delivery. Actually, much of it is common sense, isn't it? But it's the innovation at a local level and a sort of an operational desire with clear results and ability to see what's happening, to do a 2-week or a 2-month look at your data and say, I need to do this, that, or the other, and calibrate, is what's really been shown. I think low coverage of primary prevention, and we all know every country in the world, whichever country you come from, none of us invest enough in prevention and the tough stuff. Stigma and discrimination, obviously, and I think that as Shannon mentioned, some of these legal and policy obstacles to health equity and HIV services are really, really deep rooted, and tackling those is, it's easy to talk about, but actually when you're doing a sort of 1-year planning cycle, we're doing a 3-year cycle, it's so easy to become complacent about the things you actually need to see change. And I do think that's why some of those putting ourselves on the line for some of the targets in the global health AIDS strategy is going to make it harder for us to walk away from some of those commitments. And let me stop there. And thank you. Great to be here and to listen. Over.
Thanks, a short but a lot of things to consider in there. Obviously, the issue of sexual health has popped up in all three of the responses. Integration has popped up. I really like that idea of coming to a common understanding of sustainability, because at that point, then we can start to put some goals and program to that. Thanks for that. Adrian, the next question is to you. You get the unenviable task of representing the entirety of the private sector within that. Again, the first question goes to you about are we missing something? But I'd like you to take on to kind of follow on to the previous discussion on sustainability, and because it's popped up a couple of times about the role of the private sector. Particularly in the response today, but more importantly, the sustained response over time. And again, looking at it from your lens, what can the PEPFAR program do? So over to you.
Thanks very much, Michael. Just a sound check. Can you hear me? Yep.
Yep, absolutely.
Great, thanks. You know, before I leap into the broad topic of the private sector, I first want to say that it's challenging to actually identify specific areas that haven't been included in the current strategy formulation, and you have to acknowledge the reason. Part of the reason for that is the success. You know, Angelia, of you and your team over the past several years, and becoming increasingly differentiated in the strategic approach to capturing risk populations and advancing important innovations with the private sector, like decanting, like leveraging private sector capacity, leveraging innovation and the capabilities of the private sector. So I want to start with, you know, congratulations, because we don't say that enough. Not to say that there's any room for complacency. That's probably the biggest risk that I see is somewhat complacency, and I'll go into that a little bit. But if you look at other areas of global health, and I'm intimately involved in areas such as drug-resistant TB and soil-transmitted helminths, you know, the impact of the pandemic, of the COVID pandemic, has been at least disruptive, you know, generously devastating to many of those diseases. So congratulations. I think that, you know, there are some things that are missing for me, and it's hard to talk about in a strategy where you're trying to engage and enroll people. But while it's focused, it's simple, digestible, and implementable, I think risk mitigation is missing for me. And what do I mean by that? You know, when you have so many people, tens of millions of people in the world who you're managing through a whole variety of programs across geographies, there's a critical mass and impetus to that. And so we're talking such large numbers that what worries me a little bit is that the lead indicators, like what is happening in Eastern Europe, what is happening as you look a little bit more detail, you know, regional country by country in Asia, and particularly in the pediatric population. If we have, you know, the low rates of coverage for what is in essence a very young continent like Africa, and we see that cohort of children now going through adolescence, then we have a massive potential risk in the future. I just wanted to put that out there. I don't have an answer for it, but I think at least being explicit about it. I think prevention is a little bit of a miss, and it's very, very hard because, you know, acknowledging again that we can't wait for prevention while we solve the issues of people who are living with HIV and are transmitting HIV. So, but there are tools and innovations coming. There are tools that are available today. The innovations that are coming include vaccines and other forms of long-acting PrEP, but we have PrEP today, and we have other non-pharmaceutical methods of prevention of transmission. And again, I think we shouldn't lose sight to that. It shouldn't just be implicit, it should be explicit. For the private sector, what exactly is the ambition? You know, I think it was stated really well before. There's nothing more crystal clear than 90-90-90 or 95-95-95, but what is the ambition in prevention and in the private sector? Is it X innovation? Is it X programs? Is it X dollars? I don't know what it is, but having some sort of tangibility around that, you know, might be helpful. Looking at complacency, one key piece, and it's the toughest piece, is the political leadership. And I think it would be fair to say that at least part of the early stumbling in the pandemic was the absence of strong political leadership, particularly from the US. And so while we have very strong bilateral support for PEPFAR over a decade, I still feel that it's fragile. We need to make sure that we don't be complacent about that and assume it's going to be there. The other piece is, being involved in the COVID pandemic, and I'm responsible for our vaccine deployment across resource limited settings, including Africa. I'm seeing now a lot of the same, let's say, key populations, people who inject drugs, MSM, sex workers, and so forth, people displaced populations, conflict zones, that are actually being, I would say, actively marginalized by vaccine programs in the countries in which they live. And so as we look at that, there are still very hostile environments. And I wonder if there isn't a way to think about building the better economic case with the private sector for why governments should focus on inclusive treatments, because economically it attracts more investments, more businesses. So thinking a little bit about the programming around education and maintaining people in school and finding employment, is there some way to think concretely and innovatively about that? Fragility is the other area I see huge risk and where we need to think. The pandemic really is evolving, as it was seen, every month or 2 months, and that's not going to change, I would say, in a short period of time. We have less than 2 or 3% of most of the Gavi countries vaccinated today. So while we all think we're dealing with variant control now in the US and in Europe, that's not the situation for most of the world where they haven't got their vaccine. And so we should also be careful, particularly if you think about health system resiliency, capacity, how we leverage the private sector, that we don't miss a collapse of a health system when we really do start seeing masses of infections start to come through in those environments. And we're seeing some of that start right now. I think in Africa we have Delta infections now through most of South Africa. It's changed from the Beta variant, and that's going to spread, putting more pressure, I think, on HIV programming, in particular. As we think about the other areas that we've been proud to be involved in J&J, particularly with MenStar and Dreams, it was being able to bring something that wasn't product related. It was being able to think about how can we bring consumer activation, client-centered design, how can we bring the differentiated voice of the private sector to those efforts. And I think that's a very, very important role that we can continue to play and expand on, and we should be bold about. One of the big successes I've seen in decanting and displacing patients or moving patients to private care is the ability to create differentiated care pathways, maybe in a cultural environment that's difficult for large public health services. And I think that could be broadened. But I'm gonna stop there, Michael, because honestly, I want to go back to my original comment and say, look, PEPFAR is a success story, and it's a very strong success story over the last 3 to 5 years. And this is a very strong strategy, but I do think that there are warning signs, and I don't know how to articulate well or better my concern about risk mitigation, but I think it needs to be at least somewhere implicit or explicit.
Thanks so much, Adrian. And, we appreciate the pat on the back. We do see ourselves as a successful program, and that forms the absolute basis for the political leaders that we have here in the U.S. But we're not satisfied with that, and we want to drill down and find a lot of these things. I really like that point about risk mitigation. I think we need to take that back on and really consider the implications of that, and maybe we can work with you and others. I know that that's something that we can do a lot better job of with the Global Fund as well, kind of joining up on that. So thanks for that. Peter, the last question goes to you again. What are we missing? is that I also want to probe a little bit more on COVID. This has popped up in a number of different ways. It's kind of implicit in the questioning around integration. But I was wondering if you could talk just a little bit about the effects of COVID and maybe how PEPFAR should be leveraging its platforms for other health outcomes. As I had said, I think we don't often talk about that, but there are clearly spillover benefits. So if you again can talk a little bit about the effects of COVID as well as some of these broader points would be great. Thanks. The floor is yours, Peter.
Sure. Thanks, Mike. I just want to do the same sound check as Adrian. Can everybody hear me?
Yes.
Okay, great. I also want to follow Adrian another way, make sure that I start with compliments to the PEPFAR team on the really impressive results described by Anjali at the top of the session. It's wonderful to see the scale up of all of this work and also some of the background notes that were, or slides that were sent out. Everybody in this team or everybody in this group certainly knows about the scale up of client-centered care, as has been mentioned, and you asked me to comment on the incredible dexterity shown by PEPFAR in adopting HIV services, supporting ministries of health to adopt HIV services during the COVID-19 pandemic, to maintain continuity of care, and really that overall progress towards those 95 goals. I have 3 recommendations I wanted to highlight, and in the process, I think I'll get to your COVID, questions about COVID and the effects of it. The first 2 are suggestions to address short and medium-term challenges. The third is a response to the question on how PEPFAR should leverage its platform for other health outcomes. Regarding challenges, I actually wanted to start with continuity of care. We're really now at a point in this journey to epidemic control, however we define it, and I really like the way Siobhan was talking about the operational and financial aspects of epidemic control. We're really now at this point when I think I and others would propose that the challenge of closing the final gaps and keeping them closed requires a reconceptualization of the cascade itself. I think we need to move away from this linear, unidirectional 95-95-95 continuum to a more cyclical cascade of disengagement, re-engagement, and transitions that more accurately reflect the experience of people living with HIV. Indeed, recent papers from South Africa and elsewhere have demonstrated that up to 50% of people who present as new initiators are actually not disclosing their previous ART use. And so this is where I would push PEPFAR. How can PEPFAR and the rest of us help to improve the trajectory of these people's care? I suggest that the continuity of care and re-engagement, particularly in, I think, what was beginning to become even more and more recognized, particularly in that critical first 6 months of care, is that next frontier of differentiated service delivery. And I think we've got this real opportunity to leverage what's happened with COVID in this setting. This first 6 months of care includes, during that first 6 months of care, there is an identifiable group of people entering services who we all know are at a higher risk of disengagement. These include people who have a prior history of starting and stopping ART. And PEPFAR should provide differentiated services, differentiated enhanced services to those individuals to support continuity. And then when life circumstances lead some of them to disengage from care, ensure that they are quickly identified and welcome back, rather than what we all know happens, unfortunately, is that some feel penalized, rightly or wrongly, by the healthcare workers who receive them. And in this time of COVID, when we want people for their own health and for the healthcare workers to spend less time in the facilities, the standard of waiting to start differentiated services or multi-month refills until 6 months or 12 months until somebody is established on care should evolve, has already evolved, and we need to find ways to help capitalize on that. Another way of capitalizing on it is appropriate use of digital communications, and that has certainly happened a lot. We've seen a sort of a slow, lots of pilots, slow evolution of uses of things like SMS and WhatsApp and even chatbots, and I think we've seen a real acceleration through the time of COVID, and PEPFAR should actively promote those efforts and help move that field from the sort of graveyard of pilots to scaled implementation. The second challenge I want to talk about is who and why to test for HIV in this next phase of the response. While there's obvious need to continue to focus on identifying new positives and linking them to care using innovative means like partner notification services and self-tests, there's other use cases for testing. For instance, it's well known that people seeking to re-engage with care use retesting as an entry point without disclosing their prior care history. So I ask, could HIV testing services be reimagined to facilitate re-entry into care? In addition, there's an incredible opportunity to lean into the use of testing to connect high-risk people with non-reactive results to effective prevention services. And these have been mentioned, VMMC, PrEP, no one's mentioned condoms today, but I'll put that out there as well. Referral to prevention is obviously more complex than referral to treatment. People who test negative might be less motivated to link to services, and these services are not yet as readily available in client-centered form. But like re-engagement, this is a challenge I suggest that PEPFAR should address head-on in its next strategy. Others have said, we need to define clear targets. What are we really trying to do in prevention at the community level? But we know these options are coming. There's long-acting PrEP that's right around the corner. We should be experimenting now, and I know there is a lot of experimentation happening with differentiated service delivery for PrEP for these other services. So those are important areas that we can lean in. Lastly, Mike, on your last point, I want to touch on how PEPFAR should leverage its platform for other health outcomes. I again want to compliment PEPFAR here, critical work on reducing mortality through providing services to detect, prevent, and treat advanced HIV disease itself. And there's more to do there. But as you're calling out in the question, it's also essential to recognize that people living with HIV have other health needs that affect their quality of life. For example, the primary cause of death among people living with HIV is TB. No one here, that's not news to anyone here. And PEPFAR has actually been incredibly successful in supporting the scale-up of TB preventive therapy. The scale-up was enabled by many things, but the two I'll call out are documentation of eligibility and completion of the treatment course, and then this COVID accelerated push to coordinate TPT medication supply with multi-month refills of ART. The same model of required documentation of need and documentation of clinical management with alignment of medication refills with ART could be used to address the significant unmet need for family planning services and treatment of non-communicable diseases like hypertension and diabetes. PEPFAR does not need to buy these commodities, but PEPFAR can do more on the documentation side and the alignment of the services. There's no question that there's multiple policy and practical challenges to implementing these programs at scale. But there's also numerous examples of successful integration, and some of them, like TPT, have already been accelerated by COVID. This whole recent paper very thoroughly documented all of the ways these different services have already been integrated. So I would suggest that PEPFAR use these examples as a basis to support widespread implementation of these essential services. As Meg said, COVID is not going away. We have 5 years, these next 5 years of the strategy to make sure that PEPFAR's incredible expansion of multi-month refills actually goes the next mile, so that the full impact of the innovation is felt is felt by people living with HIV who also have interactions with the healthcare system for family planning, for hypertension, for diabetes, and for all other services. Lastly, I want to point out that this support of self-care for complementary health services it's actually a logical path towards this question of sustainability and these operational aspects of of epidemic control. If we can coordinate HIV treatment programs and these other health programs that require longitudinal services, we're going to lead towards this dream, hopefully not always a dream, of universal healthcare. All of these programs require the same basic ingredients that Anjali mentioned earlier: the strong supply chain, lab tests, whose samples could be collected outside of facilities, regardless of where they're analyzed, as long as those results are rapidly used to change patient management. Data systems that can track clients across time and location, and appropriate use of digital tools and late workers to support healthcare professionals. These opportunities should be elucidated in that section of the PEPFAR strategy focused on sustainability. And critically, that document should also clearly state how country leadership will be facilitated in the development and implementation of those sustainability plans, a point which Meg highlighted as well. I'll stop there. Thanks.
Thanks, Peter. I'm going to take that phrase, a graveyard of pilots, and start to think about that a little bit more. Lots of good points there. Obviously, again, the question of integration seems to be central and something that we need to really take on. You know, a lot of other good points about the reconception. You know, you started off with the continuity of care of the people in and out, and how do we leverage that in a different way. So before we open up, I just wanted to go back very, very briefly to Shannon. Shannon, please, no more than a minute or two. But I want to give you kind of a last word and probe again on some of those things that we can, that the PEPFAR program can influence now that you've heard everybody else. So Shannon, if you want to take the floor again, it's open to you for very quick.
Sure. Let me go really brief and maybe use one element to drive through a few different issues just to sort of make it more alive. I think one of the elements I just really want to make explicit, because it applies to the 5 things I said, but it comes up with what Meg said and what Adrian said, etc., is this issue of key populations. Key populations are important everywhere in the world. They're up to almost a quarter of new infections in sub-Saharan Africa, and they're nearly, 98% of new infections in other places. And so it plays out in a few things that I think can be a litmus test of whether or not the strategy is being robust enough. Certainly on the societal enablers and decriminalization and legal frameworks, but also what is the diplomatic role of PEPFAR in upper middle income countries where the money is really not the issue, but the political will is? Because many of these upper middle income countries that are going in the wrong direction are primarily key population epidemics, and the political will to service them is not there. It also shows up in mortality and advanced disease. We have been seeing a flattening, a slowdown in our mortality reductions. And that's in part, you can take a snapshot. We are reaching some people earlier, but there's a lot of people, the same people we seem to be missing all along. And I think the PEPFAR supported FIA data shows the really substantial proportion of those who are newly diagnosed who actually have advanced disease. We can't tell you how many of those are key population members, but we can tell you all of those individuals are marginalized. They're being missed by the services that are there. And so something new is needed. And so it would just be my pitch to say when PEPFAR finalizes its strategy, it really needs to be visionary and strategic, not operational. We all, I think, are convinced that PEPFAR has some of the best operational and program planning chops on the planet. Got no fear that whatever the strategy is, it will lead to a strong operational plan. But we need the vision from the US government on the role you're going to play and how that will save lives.
Thanks so much, Shannon. So with that, I'm going to hand the floor over to David Haraz, who will moderate the chats and comments from the participants. David?
Great, thanks, Mike, and really appreciate all the comments from the panel. So we're going to dive right into the Q&A. If you have a question, please raise your hand, or if you'd rather enter your question in the chat box, we can take it from there. We'll start off with Loretta Wong. Please state your question. Thank you.
Okay, cool. Hi, thank you. I'm Loretta Wong from ACE Healthcare Foundation. I want to thank you, PEPFAR, for this great listening session. And this is actually my personal first time joining this session. So I hate to mention about COVID, but I have to say it. So given the impact of COVID-19 is still unknown in nearly like all aspects, health, finance, education, social, blah, blah, blah. And how would PEPFAR's goal and how confident, PEPFAR in achieving the 95, 95, 95, and how would that be like implemented and also be achieved? Second question is, other than COVID, and there are so many different structural barriers, including criminalization of same-sex behavior, drug use, sex work, gender-based violence, etc. And these happen daily to key populations in the context of PEPFAR's 5-year strategy. So what more can PEPFAR do to address these structural barriers? And lastly, I think it's like 70 minutes into this listening session, and there was no mentioning of condom. So does condom still have a role to play in PEPFAR strategy? Thank you.
David, you might be on mute.
Sorry, apologies. I must have gone on mute. Loretta, thank you for those questions. I think we'll sort of take those in the context of what could key inputs be to the draft documents that you've seen. So Anjali, I don't know if you want to just sort of address maybe that prevention package. A range of the panelists spoke to that, but we could talk a little bit about just the way that we're thinking about the prevention piece as far as reaching key populations and deploying some of those interventions at scale that PEPFAR already supports.
Sure. Thanks so much, Loretta, and thanks for the question and the comments. And really, I first want to just commend the panelists. That was really comprehensive and robust, and really appreciated the thoughtful input into the session. Loretta, you know, we definitely look at the prevention package in a comprehensive way. The condoms are absolutely a part of that, as is PrEP, as is a number of other prevention modalities. We simply didn't have the time to just note that in our presentation, but of course, these are priorities for us. David, I wonder if we want to take a series of comments from the attendees and then we can reflect. I know others have been looking at the questions that we submitted around and would love to hear other comments that folks have.
Great. So we'll go to Patrick first. Are you able to speak, Patrick?
Can you hear me?
Yes, we can. Please go ahead.
Okay, thanks, David. And I'm out of line. Greetings, everyone. Thanks for the opportunity. Greetings, Anjali, Mamadi, my good friends, Shannon, my boss, and others who are on the call today. Three quick thoughts, and it goes back to something that Shannon ended with a few minutes ago in terms of visionary and strategic. Three suggestions, take them as you will, and this doesn't necessarily need a response, Anjali, at the moment. Number one, I think it would be useful for the strategy to emphasize investing for success. If I take the example of the regional program in West and Central Africa, Togo and Burkina Faso have been singled out for additional investments to try and get them to epidemic transition, epidemic control, ending the epidemic. So I think that it would be important for the program to, over the next 5 years, to have a narrative of how PEPFAR is investing to get us to the end of the pandemic and highlight certain countries. You can't do everything everywhere, but picking a few, making the investments, and actually making the concerted effort, I think would be very, very useful. It would help us all in the long run to demonstrate that we can actually get to the end of the epidemic. Secondly, sustainable transition financing, and a number of the colleagues have touched on this, but actually partnering with the Global Fund, partnering with other partners to ensure that we're not just talking at governments about sustainable financing, but what are we doing, Anjali, as you know, in Cameroon with user fees, for example. How do we make that sustainable? How do we ensure that investments in health and well-being of the populations are sustained by government? And that was touched on a few minutes ago as well. What more can we do to ensure that we are investing in making that happen with the host country governments and the partners that we work with? And related to that, finally, and I'd go back to our global strategy, and that is inequalities. And I like what Shannon said and suggested, as well as Adrian, about investing in ways of ensuring that we are going beyond HIV, but that we are addressing the fundamental inequalities that are driving not only this, but many other epidemics. So how does PEPFAR, in terms of the investments the US government is making, how do you drive a whole of government response, not just to HIV, but drive a whole of government response to the inequalities that are causing not only HIV, but other problems as well. And to the extent that you can underline that in the strategy, I think that would be very helpful. Three suggestions for what they're worth. Over to you.
Thanks, Patrick. Great suggestions. Michael, would you like to speak?
Yes. Hi, everyone. My name is Michael. I just want to say thank you for the panel. Really, really informative, and for the strategy as well. Just two key things, and just going back to what Shannon mentioned earlier on around key populations. I think for me, there's one thing that's really lacking in this strategy is real, determination to work on LGBT and key populations issues in the right way. And I think I can't really see any human rights approaches being defined or included in this strategy. And I think that's a real concern for me. And another one is, like, I think we all know, like, the reason why most key populations have had issues accessing services in decriminalized communities. And I think one of those issues, or one of those key things that we have all mentioned, is, structural interventions. And I think it's really lacking and that's very glaring in this strategy right now. And I want to know, like, what is your intention, or what is your approach to reaching key populations, knowing what we know, knowing what the data has told us about the reason why key populations are not accessing services, are those key structural issues. And we've defined structural interventions to PEPFAR over the past couple of years now about how we want to be reached as key populations. And I think looking at this strategy and still seeing that's still lacking is a real concern. And also, I think, it's not just about including structural interventions, it's actually, programming and budgeting for it, and working people on what that means for them and how we can reach them through those interventions. We have examples, and I think we can pull from some part of KPIF about what has worked and what hasn't worked. And I think also the lack of PEPFAR to do a real impact evaluation of what happened with KPIF is also, for me, also very surprising. I think, most of us, we still don't know if KPIF was a success or not. And from community perspective, we most of us think it wasn't. But I think from PEPFAR, our province to know what worked with KPIF and how we could do better, and not just move everything to COP funding. So I think those are like my key points, and also just re-emphasizing again about LGBT and human rights approaches and how we want going to reach those populations. Examples what's going on in Ghana right now and other countries, and where we have laws and decriminalizing laws that are making key populations not access services. And another one before I drop the mic is about, like, how we use new interventions. I think one of the things you listed here was about new approaches, like, I'm sure talking about the rings and injectable PrEP. But I think, how do we work with populations to make sure these new interventions are suitable to them, and how would they want to assess these new interventions? And I think that part is also not as clear to me, as I also want to know what is the approach and what is the guidelines that you have in place. Are you going to work with WHO and PEPFAR, and Global Fund, and also, like, the coordination between Global Fund and WHO and UNAIDS and PEPFAR? Has it been as clear as it should be? And we need more clarity about how PEPFAR, Global Fund, and WHO are working together to reach communities, and what is the communication channel between those organizations? How are you sharing out what you're discussing to communities? Thank you.
Thank you. Thanks, Michael. Appreciate those reflections. Other reflections or suggestions based on the dialogue and what you've seen? I think we have one raised hand. Please go ahead.
Can you hear me?
Yes, we can. Please.
Sorry, it's Martin Donahoe here. I'm with the World Health Organization in Ukraine, but there's a lot of things that have been said and raised applicable to Ukraine, but also more generally. Just two of the points I want to pick up on. One, the issue around telemedicine. The whole issue of telemedicine has really come to the fore during COVID in Ukraine and in many other countries. But if I see another app, I'm going to cry, because there are part of the issue is about the quality of the information and the recognition that telemedicine is not just about another app. We really need to look at the quality and have a better working definition of what's covered in telemedicine. I've recently been part of the team reviewing the Global Fund's the response mechanism a proposal, and there was plenty of proposals there for various apps and to support telemedicine without really getting to grips about the quality of the telemedicine. The other issue is, in Ukraine, as in many countries, there were some really good, I'm not going to call them innovations, because there are things that we've been trying to do for years. The multi-month dispensing, community delivery of antiretrovirals, the shorter time period between first presenting a treatment and then initiating treatment. And there's been real improvements. I'm a little bit concerned that as the COVID the COVID epidemic's not over anytime soon, but I'm hearing that once the COVID epidemic is over, we can go back to normal. So it's really important to make sure that these interventions remain and are sustained even after COVID. So I don't think there were any questions in there. There were just a couple of reflections from the country level, and thank you very much for giving me the floor. Thank you.
Thanks, Martin. Appreciate it. Emily Gibbons, over to you.
Thanks, David. Can you guys hear me?
Ken.
Okay, great. Well, thank you for everyone, and I'll make this brief because I know that we're close to time, but thanks to Anjali and to the team for convening such a robust discussion. It's great to see so many familiar faces on the stage today. I just wanted to have a quick follow-up question on something that, or comment on what Michael had said, and really to commend both the UNAIDS strategy and for PEPFAR for the focus on making sure that there are innovative therapies and prevention modalities going forward. Certainly, this is an area in which the private sector, I work for Merck, feels that we can make the strongest contribution to the epidemic. And I think many people on this call know that we have a partnership with the Gates Foundation. We are actually in phase 3 trials now in sub-Saharan Africa on a long-acting novel PrEP for 1 month. So I think that this is both this implementation and then also a longer-acting implant is something where we think that we could both make a contribution, but also, to Michael's point, really want to work with PEPFAR and the Global Fund and other key partners on making sure it's implemented correctly and actually getting to the folks that that need it most. So I just wanted to, again, say thank you for convening this. I would be remiss if I didn't say that we are also appreciative of the work by UNAIDS and PEPFAR and the Bush Institute on the work with cervical cancer on the Go Further partnership. But we are happy to partner with you going forward, and thanks for your work so far.
Great. Thanks, Emily. I don't see any other hands raised, and I think we're at time for this portion. Just to let folks know who've put comments and suggestions in the chat, we are capturing all of those, and we'll be incorporating those just as we have the verbal suggestions raised over the phone. We just have about 10 more minutes left, and I'd like to turn it over to Mamadi Yilla on our team, who's been our rapporteur for this session, to hopefully reflect back some of the through lines that we've heard in this discussion. And again, this is just the beginning of the listening session process. So appreciate all of your comments, but over to you, Mamadi.
Thank you so much. I am so proud of the panel that we assembled this morning, because you came and did exactly what we wanted, which wasn't to tell us that we're great, but instead to say where we could actually lean in and make a better, promote a better strategy as a result of your inputs. So we have note takers who have done an incredible job in terms of capturing everything that was offered today. And I just want to reflect on a few things that I felt we all heard you say and want to summarize here. So we want to thank our UNAIDS partners, and Shannon, thank you for coming and reminding us that we are good at operationalizing things, and what really you want to see from the US government is that bold vision and leveraging our whole of government effort, both in our diplomacy space as well as in our development space. I think that we heard you, Meg, with regards to the clear role of government that must be emphasized in our strategy. I think we've seen some unexpected tension by the use of communities at the center of a lot of the work we've been doing around the Global Fund strategy, and that not being in any way, shape, or form a desire to minimize the important role of governments. But we also heard about the places where a lot of, especially those concentrated epidemics, where governments are choosing not to serve the populations that are in need of service, and how important it is that we actually speak to that and encourage a better approach because of the morbidity that is being contributed by the populations not being served. We heard you also talk about organizing at the country level to avoid duplication in the data systems, laboratory systems that are being born out of our response to the COVID pandemic. So we heard that. Siobhan, wow. Okay, so I was really struck about the interpretation of a strategy that was leaning more towards pandemic response than the opportunity for universal health coverage. And Peter definitely spoke to this in a way that I think a lot of people heard today about just how we can leverage the moment that we are in and actually put aside some of the terminology and just really ask how we can serve populations where they are at right now, as opposed to the way we get bogged down with terminology sometimes. You said silence on sexual health is troublesome, and I think that we all heard that, and within the US government there has been a lot of discussion about the opportunity we have for further integrating what we know must be done that perhaps hasn't been addressed as it should have. Adrian, thank you, that making the economic argument to governments who are not tending to the inequities is a potential way forward. I think what we wanted to hear today were some of the solutions or some of the recommendations for the challenges that we see. Your comment about risk mitigation really also struck a chord. I don't think we use risk mitigation enough in the PEPFAR space. We definitely, in our participation, in our collaboration with the Global Fund, and appreciated the things that you offered. I also thought it was useful that you let the public who are here know today that your participation with us in Men's Darn Dreams wasn't about bringing product, but that differentiated voice and the power of decanting services, for example, that the private sector showed us how to do. Peter, wow. I think you made such excellent points today about how we need to transform some of the way we have thought about things and reconceptualizing the cascade, that it not be as linear, but more cyclical, and the work we could do to actually reach the people who will later engage in those first 6 months that we have them in front of us. Your comment about digital communication and moving from the graveyard of pilots to scale up was definitely heard, and Mike commented on that as well. So I'm going to stop there in view of time, and to say that your inputs today, we will take on, because this is really what the strategy is supposed to be. It is supposed to be a strategy that belongs to everyone who's partaking in this world, in this effort, not just those of us on the US government side. I want to also thank our implementing agencies who are also together with us at SGAC hosting these listening sessions this year, because as you know, we put out a strategy, but they are instrumental in making those things happen. So want to just acknowledge them as well. Apparently it's my job to say thank you to each and every one of you. We appreciate your time. We appreciate your candor, and we look forward to you continuing to engage with us. And thank you, everyone, really from the bottom of our hearts. Okay, bye-bye, everyone. See you tomorrow.